So I'm going to talk to you about relapsed and refractory multiple myeloma. This has gone from a very limited subject with limited successes to now a subject in which we have an extraordinary number of resources and correspondingly a much more difficult time in terms of making therapeutic decisions. So I think this has become one of the most rapidly evolving areas in all of hematologic malignancies and probably in terms of oncology in general. So the first question that we have when we have a patient whose disease is relapsing is, should we treat that patient? Do we use the same kind of criteria to make a decision about managing a relapse patient as we did for a newly diagnosed patient? Meaning, do they meet CRHM criteria? Do they meet diagnostic criteria for multiple myeloma? Clearly, that is not the right thing to do for all patients, although it may be the right thing to do for some patients. So for those who had very aggressive presentations, those who had very high-risk presentations, and I don't mean high risk in terms of the genetic markers that predict ultimately for outcome, but I mean high risk in terms of having had renal failure, having had hypercalcemia, having had extensive bony disease, or any other manifestation of their myeloma. Obviously, those patients need to be treated earlier. So it is a very complicated subject, and one which unfortunately there is no absolute answer, and that's why physician is an art, being a physician is an art rather than a technical field. So what considerations do we have when we see that patient who's relapsing? We need to consider what therapies they've had previously. Were they transplanted? Did they have toxicities related to therapy? Do they have continued peripheral neuropathy? What are the patient-related features? Is the patient older? Is the patient younger? Is the patient physiologically intact? Is the patient not physiologically intact? So this is a very complicated field, and it is complicated enough that one cannot say this is how you treat a patient with relapsed or relapsed refractory multiple myeloma. We continue to need to use our judgment. So what has happened in the last several decades to the management of multiple myeloma? We know that when patients get treated, they become progressively less likely to respond to subsequent treatments. And until very recently, when a patient was identified as being refractory to bortezomib and lenalidomide, the prognosis was extraordinarily poor, that the median survival for a patient who had become refractory to lenalidomide and bortezomib as recently as several years ago was less than 9 months. So this is the arena in which we are stepping with all of the new modalities that we have. So how fast has myeloma evolved? Well, the first the first documented case of multiple myeloma is in Egyptian mummies. So to say that the first case was in 1830 is perhaps a little bit of a mischaracterization, but it was first described as myeloma back in 1844. We have evolved very quickly, and more quickly as time has gone by. Not included on this list is the single therapy that I think has made the greatest difference to multiple myeloma patients over the last generation, and that is not a specific anti-myeloma therapy. I think the most important single intervention during my lifetime certainly was in the early 1990s, the availability of pomidronate. And for those of you who are younger, and most of you in the room are substantially younger than me, you don't know what myeloma was like a generation ago. It was truly the most difficult oncologic problem to witness of all oncologic problems, as patients slowly died skeletal deaths. With the availability of pamidronate in 1990, 1991, that changed entirely. So we have a number of new drugs. Actually, the very first patient to be treated with thalidomide, which I think was the entree into a new era of treating multiple myeloma. That first patient to receive thalidomide was actually my patient. And we treated that patient with thalidomide not because we had any particular insights as to the role in biology and why thalidomide would be useful. We treated that patient with thalidomide because that patient's wife actually insisted that we treat her husband with thalidomide. So I think the dawn of this new age of rapid evolution of new drugs and new availability of drug combinations was ushered in by a young woman who did research on her own. She was not a medical professional. She was actually an attorney, and she said, "Why don't you treat my husband with thalidomide?" And I think the world has changed dramatically since that conversation. So, what do we have today to treat myeloma? A few years ago, we had steroids and alkylating agents. This is what the list looks like today. Quite a remarkable change in a relatively short period of time. But because of that, we now have a slide that looks like this. So you're not meant to be able to read this. You're only meant to understand that there's a lot of stuff on that page. So this is the NCCN guidelines for the treatment of previously treated myeloma patients. And this list is enormous. And this list is not confined this list does not encompass all of the potential combinations that we have, nor does it encompass all of the combinations that we use. So this is a scary looking slide from the physician's perspective. It is actually a very comforting slide from the patient's perspective. This is just one institution, relatively simplified, and I think perhaps oversimplified, the diagrammatic representation of how we should approach patients with multiple myeloma. So on maintenance versus off maintenance with a relatively circumscribed set of options available, and I think that this is difficult. Again, I'm not showing you this slide because I expect that everybody should remember the data from this slide. I am just showing you a relatively incomplete representation of some of the work that has been going on in the recent past in the world of relapsed and relapsed refractory multiple myeloma. Look at this. I mean, we have in early relapses regimens that will achieve response rates of 87, 85%. That's remarkable. When I first started taking care of myeloma, we didn't come anywhere close to that with newly diagnosed patients, and when we started to routinely transplant those newly diagnosed patients, we didn't get results that looked like this. So the myeloma world has evolved very, very quickly and continues to evolve very, very quickly. So what's the first drug we should talk about? Well, I picked pomalidomide, not for any particular reason. It is probably one of the two most active drugs that we have the opportunity to use in the multiple myeloma world right now. It has been an effective drug in patients who are very heavily pretreated. You can see here that the combination of pomalidomide and low-dose dexamethasone had a response rate of 34%. And this was enough for the FDA to give accelerated approval to the combination of pomalidomide and dexamethasone in patients with relapsed or relapsed refractory multiple myeloma. These responses were durable, with a median of 8 months, and in general, pomalidomide is exceptionally well tolerated. For those of you who have used a lot of lenalidomide, when you start to use a lot of pomalidomide, the experience is going to be very, very similar. Perhaps a little bit more peripheral neuropathy than lenalidomide, and depending on who you talk to, perhaps slightly less myelosuppression than lenalidomide. Having noted that, an exceptionally good drug. And there's been a number of follow-up studies that have led to the final approval of pomalidomide by the FDA, and this is a drug that shows an extraordinary level of efficacy against a wide variety of patients with a wide variety of presentations and prognostic variables. So the response rate is, I think this number right there is perhaps the most important one to look at, that even in lenalidomide refractory patients, the response rate to the combination of pomalidomide and dexamethasone is quite robust. So an extraordinary addition to our myeloma armamentarium. So we move on to the next. I don't want to use the word copycat. This is not a drug that is structurally related to bortezomib, but the second of the proteasome inhibitors to enter use in the management of multiple myeloma, and that is carfilzomib. So carfilzomib is an epoxy ketone tetrapeptide. It is a very volatile chemical group with a small peptide backbone that drags it to the proteasome. That epoxy group then binds irreversibly to the proteasome and inactivates it. So unlike bortezomib, the cell needs to resynthesize the proteasome in order to recover activity. The drug does not diffuse away as does with bortezomib. So based on a phase 2 trial, the 03A1 trial, which I was fortunate enough to lead, that led to the accelerated approval of carfilzomib. So 23% response rate in a very heavily pretreated patient population, with some patients showing extraordinarily durable responses. So subsequent to that accelerated approval, there have now been a series of 2 additional trials that have led to the sort of final approval of that. The first of these trials was a randomized trial of carfilzomib, lenalidomide, and dexamethasone versus lenalidomide and dexamethasone alone. Here are some of the demographics of that trial. I will not dwell on that. This is the sort of, I guess, the money slide showing the response rate to the combination of this is the description of the groups. It was a very well-matched group. But this is, in fact, the money slide showing a substantially higher response rate in patients getting carfilzomib, Revlimid, and dexamethasone versus Revlimid and dexamethasone alone. The median duration of those responses approached 29 months. This is the highest this is the longest duration of response, the longest progression-free survival that has been noted in any large randomized trial in the multiple myeloma world. So this is a very, very gratifying experience. I apologize that this is difficult to see. I think that one of the most important things to talk about when we talk about carfilzomib is toxicities. But one of the things that I would like to point out here is that less patients discontinued therapy because of toxicities in the carfilzomib arm than in the lenalidomide dexamethasone alone arm. And it should be recognized that patients remained on therapy for more than 50% longer on the carfilzomib arm. So there is a perception that this is a very difficult drug to tolerate. And certainly there are toxicities that we need to talk about, and we can do that in a second. But the reality of it is, in this randomized trial, the likelihood of discontinuing therapy was decreased by the addition of carfilzomib and not increased. So I think a very important point. So what else do we need to talk about in the carfilzomib world? Well, we decided to confuse the situation. So we had established 20 milligrams per meter squared, followed by a dose escalation to 27 milligrams per meter squared as the standard therapeutic course for carfilzomib. Well, some debate as to the relative value of carfilzomib to bortezomib, so it was elected to do a head-to-head trial of carfilzomib dexamethasone versus bortezomib dexamethasone. But the MTD of single agent carfilzomib is in fact not 27 milligrams per meter squared, it is 56 milligrams per meter squared. And so this is a randomized trial of carfilzomib at that higher dose versus bortezomib at its standard dosing and schedule. And this is what we see. We see a progression-free survival that is substantially better with 18.7 months versus 9.4 months, and a hazard ratio for progression of disease of 0.53 for those patients being randomized to the carfilzomib arm. So in this head-to-head comparison, we see a remarkable advantage. Now, is there a particular subset of patients that benefits more? The reality of it is, in all but the very, very small subset of patients with substantial renal insufficiency, there was a uniform advantage to being randomized to carfilzomib versus bortezomib. How about patients who had seen prior therapy? Well, again, there was universally an advantage to receiving carfilzomib as salvage therapy relative to bortezomib in all of the various prior treatment schemes that were imaginable. So here we see the complete response, the VGPR, and the overall response rate. So substantially higher response rate, the substantially higher number of deep responses in those receiving carfilzomib relative to those receiving bortezomib. Now, I think that this is a slide that we need to pay particular attention to. There is certainly a signal of higher cardiac events, of higher, at least subjective pulmonary issues in carfilzomib relative to bortezomib. So you can see that cardiac failure events are basically twice as high in patients receiving carfilzomib than in patients receiving bortezomib. Now, much of this is an early event, and the way that the protocol is written is patients receive very aggressive hydration. I think we need to be very conscious of the baseline cardiac status of our patients, and we should not just uniformly aggressively hydrate all patients receiving carfilzomib as part of their initial management. We need to be very aware of that. We need to make sure that these patients are appropriately diuresed, et cetera. The number of respiratory events was not a significant issue in this particular trial. And I would point out that if you compare the data from ASPIRE, where the carfilzomib was administered at 27 milligrams per meter squared versus the cardiac events seen in ENDEAVOR, where the carfilzomib was applied at 56 milligrams per meter squared, that there was no substantial difference in the likelihood of having those kinds of events. So this is certainly not a dose-dependent phenomenon. I'm not going to talk in significantly greater detail about this. In terms of peripheral neuropathy, carfilzomib is associated with a much, much lower incidence of peripheral neuropathy. This is not FDA-approved therapy, not officially available, although it is widely used. Carfilzomib can be used in a number of combinations, and I'm just briefly showing you this, is that the combination of carfilzomib, pomalidomide, and low-dose dexamethasone has been studied in a very, very heavily pretreated population. Response rates were quite robust, and so I think that we have to understand that carfilzomib, like its predecessor bortezomib, makes an excellent companion drug to others. So its ability to be used in combinations is quite exciting. So now we come to elotuzumab. So elotuzumab, I'm sure you all know, is a monoclonal antibody directed against SLAM-F7. SLAM-F7 is fairly ubiquitously expressed on plasma cells, particularly malignant plasma cells. It is also an activating receptor on natural killer cells, especially natural killer cells that are low-level activated already. How important that is in the activity of elotuzumab is unclear. In any case, the randomized trial, the ELOQUENT-2 trial, that looked at patients receiving Revlimid and dexamethasone versus elotuzumab, Revlimid and dexamethasone, led to the approval of that three-drug combination, ELO-RD. This is the structure of the trial, patients with 1 to 3 prior regimens. And here is the progression-free survival for the ELO arm and the overall response rate for the ELO arm relative to the combination of lenalidomide and dexamethasone. So the first monoclonal antibody to receive approval in the United States for the treatment of multiple myeloma, I think a truly historic moment in the management of multiple myeloma. And again, here you can see the response rates. Now you'll notice that the complete response rate is lower, but you can't document complete response in IgG kappa multiple myeloma patients because the elotuzumab is an IgG kappa monoclonal antibody, and when you administer it to patients, it makes the immunofixation positive. So you cannot actually document complete responses in patients who are actively receiving elotuzumab. And here you can see the Kaplan-Meier curve showing a significant improvement and a hazard ratio, a hazard reduction of more than 25% for patients randomized to the elotuzumab arm. So we have finally joined the lymphoma world and the solid tumor world as having a monoclonal antibody that is active in multiple myeloma. And BMS, the sponsor of this meeting, deserves accolades on that. It is actually a very well-tolerated drug. The most important issues are related to infusion reactions, and there is a very well-described and proscribed regimen for the administration of elotuzumab. So if you haven't used it the first time that you use it, it can be a difficult day. Now we come to ixazomib. So ixazomib is an oral boronate proteasome inhibitor, a very close derivative of bortezomib. It was studied in the tourmaline trial, a randomized trial of lenalidomide dexamethasone versus ixazomib, lenalidomide, and dexamethasone. And as you can see here, this trial included a significant number of patients who had seen prior bortezomib, and in fact, most of these patients had received prior transplant as well as IMiD therapy as well. Response rates were certainly higher for the ixazomib arm. The median duration of response was improved by a full third, and again, this led to the approval of ixazomib in combination with lenalidomide and dexamethasone in early relapse multiple myeloma. There was no specific subset of patients that did not benefit from ixazomib, and in fact there is a hint for the first time that ixazomib SA therapy may normalize the risk associated with the 17P, although I think that is very early and very speculative.
We have 2 minutes.
All right, I will hurry up. So the tourmaline safety data, again, well tolerated, some peripheral neuropathy, although not like bortezomib. We have now had a histone deacetylase inhibitor approved in the management of myeloma, again, in a randomized trial. We have a number of additional monoclonal antibodies that are either approved or in clinical trials awaiting approval. I think clearly the most important of these is daratumumab, and you can look at this waterfall plot to just get a quick impression of how good a drug this is. It is an extraordinarily active drug, and in as a single agent, it is the first monoclonal antibody that has single agent activity in the management of multiple myeloma. It has been used in combination with lenalidomide with substantially improvement even in lenalidomide refractory patients. So in my practice in the use of commercial daratumumab, we use it almost exclusively in combination with an IMiD. Briefly, SAR, another monoclonal antibody produced by Sanofi, very good activity in a number of situations, and perhaps most interestingly, pembrolizumab, that is one of the checkpoint inhibitors, is able to achieve responses in, let's get to that, in patients who are previously lenalidomide refractory. So the combination of lenalidomide and pembrolizumab has responses even in lenalidomide refractory patients. Pembrolizumab by itself has no single agent activity. We have used CAR T cells in myeloma, and the anti-CD19 CAR T cell. There has been one patient described who had a very short remission after a MEL200 transplant, who has had a much more protracted remission after a MEL140 plus CAR T cells. You can see what it did to the bone marrow. Whether this is entirely attributable to the CAR T cell or to the transplant itself is very hard to understand. We have all of these additional targets that are being analyzed, and I think it is a very exciting time to be working in the myeloma field, and we are going to continue to see it change extraordinarily quickly over the next several years. I think we probably already have the tools in our hands to